name is Dr. Ahmed Sufyan. I'm a ear, nose, and throat specialist who specializes in facial plastics and reconstructive surgery, and board certified in both of those areas. So what I'd like to do today is look at, first of all, define what nasal airway obstruction is and look at the causes. There's different treatments depending on the cause of your nasal obstruction. Medical therapy, surgical therapy, and we'll dive into that and define the differences and look at the treatment options. So nasal airway obstruction has both medical causes, and these can include allergies or what we call allergic rhinitis. That's what people feel during the spring and the summer and the fall. These are mostly due to pollens and allergens that enter the nasal airway. There's also non-allergic rhinitis. This is a different problem that leads to the same, meaning that it's not allergen induced, but it does lead to nasal obstruction, and we'll explain the differences. And then we'll talk about some of the anatomical abnormalities, and these are structural abnormalities. People that have what we call nasal valve collapse or weakness in the cartilages of the nose, deviation in their septum, crooked nose that's causing obstruction. There's a structure in the nose called turbinate hypertrophy that is seen, basically an enlarged structure that can cause difficulty breathing. Cost of treating patients is in excess of $7 billion a year. So many people suffer with these, with this particular problem, and an additional $60 million is spent on surgery alone. So, you know, up to 13% of the population has nasal valve collapse, which is weak structure. And we'll go into that in each one of these categories. Nasal airway obstruction, or just people complaining that they have difficulty breathing. Typically, there are medical causes, and these are allergic rhinitis. That's the common allergy. And then you have the non-allergic rhinitis. Allergic rhinitis is due to allergens such as dust mites or weeds or ragweed, essentially any allergen or pollen that can go in the nose and lead to swelling and blockage of the airway. For non-allergic rhinitis, patients will complain of the same symptoms as allergic rhinitis, except they're really not allergic to anything. So if they had allergy testing, the allergy testing would reveal that they're not allergic to anything. This is usually due to kind of the nerves that are supposed to control the nose. Basically, there's a dysfunction of that, meaning that when we go out in, for example, a day like this where it's cold and snowing, our bodies want to protect heat loss. So your nose will swell up and sometimes you get a little drainage. That is a normal response to the weather. However, we have people that sometimes every time they eat, their nose will swell up and cause obstruction. That is not normal or abnormal. So next slide. So allergic rhinitis is basically the usual hay fever symptoms: congestion, runny nose. Rhinorrhea means runny nose, sneezing, itching, itchy eyes, and it affects all the membranes, not only of the nose, but the eyes, the mouth, the ears. So any lining within our ear, nose, or our throats, basically the skin of the internal lining is all the same. It's all responsive. Even the lungs, sometimes patients will have asthma, and it's because all these tissues respond to the same stimulants. And these are antibody mediated. So what happens is you have an allergen go in the nose and it leads to inflammation and swelling and the symptoms. And this can affect up to 1/3 of the population. This slide shows kind of what happens. The allergen over here on the left side, you can see it can basically, when the allergen gets into the tissue, it leads to this activation of a cell known as the mast cell. And the mast cell releases these proteins and mediators that essentially lead to your symptoms, cause the sneezing, the irritation, the drainage. There's also another pathway where antibodies are involved, and this is to do with memory, and this is the more severe reactions. So we'll talk about how we treat this on the next slide. Before the treatment, what we do is we'd like to test and figure out what patients are allergic to. And usually in outdoor, you can have trees, grass, weeds, pollens, mold. Indoors, the usual suspects are dust mites. If you have pet danders, cockroaches, mold. And basically the way we figure out what patients are allergic to is obviously the history. Every time I play with my cat, this happens. And then the clinical testing of that suspicion proves what they're allergic to. And then looking in the nasal cavity and looking at the tissue, the inflammation, we're able to figure out that they're allergic. Non-allergic rhinitis, I touched on this a little bit. Essentially, it's an abnormal dysfunction of the nose where the nerves are sending signals to the nose to swell up inappropriately. And a lot of times this happens when patients eat. Sometimes it happens when they smell a perfume or a chemical. So they react as if they're allergic to, but when they have an allergy test, everything comes up clear. Treatment for these patients is a little more challenging because they don't respond to the usual treatments, which we will talk about in our next slides. They tend to respond better to surgery. So what are the treatments? For patients who have allergies, we typically will use nasal steroids, sometimes oral steroids if it's severe enough. Decongestants, a lot of times patients will use decongestants. I'm not a fan of decongestants and all. And the reason is that over a long-term use, this can actually lead to more problems, more swelling in the nose, more obstruction in the nose, and it can lead to kind of worsening of their symptoms. And in the short term, the first time they use it, it will feel great. They'll be able to breathe. But long term, there's really no role in the treatment of allergies for decongestants. Nasal and oral antihistamines. These can either be nose sprays that contain an antihistamine like Benadryl, Zyrtec, Claritin, Allegra, Zysol. They all work about the same. And the nasal steroid helps more with the swelling. The antihistamine helps more with the itchiness. And so they work synergistically together. So most patients that have mild to moderate disease will be on both an antihistamine, either a pill or a spray, and a nasal steroid. There are other devices that people use. For example, breathe right strips. You see many of these athletes will wear this to expand their airway, to open their airway. These are temporary things you can't use long term. And then nasal stents or springs, other things that kind of stabilize the airway. Again, temporary devices that you can insert into the nose that allow you to breathe better. Next slide. Just a comment on Afrin here. That's a decongestant. Again, I said that there's no role in treating, so don't ever use this, otherwise it will lead to more problems. So here, this slide is kind of a busy slide, but essentially what it's trying to do is highlight the different treatments depending on the severity of allergies. People that have allergies, we like to start with a environmental control, figure out what they're allergic to and kind of avoid that. If you're allergic to horses, maybe a good idea not to be around horses. Maybe if they have a lot of hay fever symptoms, we give them an antihistamine at bedtime. Well, if they have a lot of swelling in their nose and their symptoms are a little more severe, we add a nasal steroid and an antihistamine. And essentially, we continue with this treatment. And if they, with all, including a nasal steroid and antihistamine, continue to be symptomatic, then we begin to think about potentially doing allergy testing and possibly immunotherapy. So immunotherapy is essentially shots or drops. We figure out what the patients are allergic to. And the way it works is you give patients essentially the same thing that they're allergic to in small doses. And over a period of a few years, this will tell the body, the immune system, to deregulate. And instead of this allergic reaction, patients will then become immune. So it's really reserved for those patients that continue to be symptomatic and failure to respond to medical treatment. We then will also do possibly treat them with either shots or drops. Drops are basically work the same way as shots. The difference is use them underneath the tongue and they can be administered at home, where shots are administered in our office. So what are some of the side effects of treatments of allergies? Well, A lot of times patients will complain that they're allergic to a component of the nasal spray. Maybe the preservative can give them headaches, cause nosebleeds, throat irritation. Sometimes patients will report that they squirt it in their nose and makes them sneeze, burning, bad taste in their mouth. These are all common side effects of the treatments of allergies. What happens to patients when they essentially leave their allergies untreated? If you look here on the left, we have a patient who's untreated with swelling of the tissues. Here's an example of an image of inside the nose. On the top image here, you can see there's really no space. Everywhere that's black is space for air to travel, and there's not much of it available here. The septum's on the right. This thing called the turbinate, which is a normal structure, is pretty swollen, and there's actually physical contact between the turbinate and the septum. Therefore, it would be really difficult for this patient to breathe. Here, when we look at these images, the CAT scan on the right shows a normal CT scan. On the left here, you can see this kind of gray fluid underneath the eyes. This is a slice going through the sinuses in the eyes. And that fluid there is what happens when you have sinuses that are blocked off and there is essentially fluid trapped. So patients that have untreated allergies could then go on to develop some kind of chronic sinusitis and polyps, which leads to kind of more severe disease, needing more surgical intervention. Next slide. So let's talk, we're going to shift a little bit about structural abnormalities. Now, many times it's not just either allergies or structural. A lot of patients have both. Structural abnormalities are a deviated septum, nasal valve collapse, and we'll go into depth explaining what nasal valve collapse is, the crooked nose, and the turbinate hypertrophy, which is swelling. We'll go through each one of these. So first of all, we need to just kind of define some of the anatomy here. And this is a side view of the nose here, and you can see these structures that are labeled inferior turbinate here on the bottom. When air goes in the nose, it goes in the nostril, and this is basically a split view of the kind of a head. So air is going in the nose, and then it typically will travel on the floor and go down into the lung. On the image on the right, this shows a cross section between the tip of the nose, and basically the septum's in the middle, and the space in between this kind of triangular shaped cartilage is our airway. Do they see my pointer? Do they see? No, they don't. Okay. So next slide, please. Okay. Here, if you look at the structure on the right, or the picture on the right, there is a teal or green structure. This is basically the cartilage of the nose. This is the way it's supposed to look. This cartilage is what stents open the nose. And patients that have weak support, and on the left, we see the image showing basically the nose, the nasal bones. The green structures are the cartilage that basically keep our nose open. Next slide. And in some patients, that green cartilage here is depicted brown. Again, here's the nasal bones. But in that other view, the cartilages were more horizontal. Here, they're more vertically oriented. And why is that important? Next slide. When the cartilages are vertically oriented, there's only support at the front or the tip of the nose. So when a patient takes a breath or breathes in through their nose, the nose will completely collapse. Again, here on the left, you can see this young female has kind of a characteristic shape to her nose. We call this the parentheses nose. And the reason it's called the parentheses nose, there's curvature on the tip of the nose, which tells me that those cartilages are kind of going upward versus horizontal. If they were horizontal, they provide more support on the side of the nose. So when a patient breathes in, this gentleman here is taking a deep breath in, his nose completely collapses. Next slide. Here's a patient that has a deviated septum, also takes a breath in. You can see complete collapse on the left side of her nose. Next slide. And here's an endoscopic view looking inside the nostrils. And the image on the right is when the patient takes a deep breath inward. On the left is a picture at rest. And you can see there's not a lot of space. So when they breathe in, the complete collapse inward. A lot of times patients will come over and say, well, if I just kind of pull my cheek over, I'll be able to breathe better. This is called the Cottle Maneuver. And what they're doing is stabilizing their cartilages when they breathe in. Next slide. Here you can see what we like to do in the clinic is we like to, because if you pull your cheek kind of artificially over exaggerates, we like to stabilize the cartilage, and we ask patients to take a breath in. When they breathe in, we can resist that collapse, and that will mimic what surgery would do. Here is an example of what patients do by wearing a Band-Aid or a Breathe Right strip. A lot of time athletes will wear this. This is a temporary solution to the problem. It's really difficult to wear a Band-Aid every night, because what happens when you take the Band-Aid, it kind of tears the skin off, but it works quite well. Next slide. So deviated septum. What causes deviation in the septum? It could be congenital, meaning as you grow, the nose has to push a lot of, or the septum has to push the growth of the nose outward. Otherwise, you'd have a tiny baby nose. So that's why our noses grow as an adult. And the septum has really three components. Here on the image on the right, there's a blue portion called, and it's labeled as septal cartilage. There's a thin bone, which is called the perpendicular plate of the ethmoid, and the vomer bone. These three structures make up a wall that split the left and the right nasal cavity. On the left side, there is a picture showing a septum with some of the sinuses. It's an oversimplification, but basically you can see it's a divider. Next slide. Here's an endoscopic view looking at the septum in patients that have deviation in their septum. And you can see the septum is kind of jabbing into another structure called the turbinate. And there should be a black space there, but instead we see essentially we see a blockage from the deviated septum. So when we reshape that septum, here's an example of a patient that has a deviation. You're looking as before and after. On the left is before, the septum is sticking out on the airway. On the right view, you can see after the repair, the airway's patent. So now we're going to shift away from the septum. We'll talk about turbinates. Turbinates are normal structures. We have three of them. And if you look at the image on the left, the bottom turbinate is really the main turbinate that leads to nasal obstruction, because air goes in the nose. It doesn't want to go, it basically travels on the base of the nose and goes down to the airway. So if your turbinate, which is a normal structure, and its function is to humidify air, to filter the air, and to keep, actually improves oxygen extraction. If it's enlarged, it can actually become an obstruction and lead to blockage. So we have three turbinates, and really just the bottom one is involved in regulating airflow. Next slide. Here on the left, you can see a patient that has a really swollen turbinate. And on the right, you can see after the turbinate is decongested or treated, that turbinate, there's a lot more black space, which is space for air to travel. So many times, in patients, we have to not only treat a deviated septum, but we need to treat this turbinate. A lot of times patients will say, when I lay down, sometimes, my nose feels like it blocks off. And the reason that happens is that turbinate will pull some of the gravity, will pull some of that fluid and blood flow to the nose and lead to obstruction. This picture is a picture of a crooked nose on the left. And you can see if the cartilages are all twisted, they can lead to kind of blockage. On the right image here, you can see that cartilage has been repaired. And not only is the nose straighter, but the breathing is improved. Next slide. So what happens to patients that have nasal obstruction, even if it's caused by a deviated septum, weak cartilage, or crooked nose? A lot of times those patients default to breathing through their mouth. And if you breathe through your mouth, it leads to a dry mouth, which can lead to bad dentition. I mentioned that breathing through the nose filters the air, humidifies the air, and improves oxygen extraction. And patients that breathe through their mouth tend to have less oxygen absorption, and they have to work harder to breathe. And a lot of times that leads to restless or, non-restful sleep. Next slide. What are some of the treatment options we utilize to repair the kind of anatomical or structural problems? Septoplasty is repair of a deviated septum. People that have weak cartilage, what we call nasal valve collapse, we can do what's called a batten graft. People that have kind of crooked noses, we can do spreader grafts. These are all different cartilage grafts that we use to improve the structure. And I'll show you examples. And then finally, people that have swelling in their nose due to turbinate enlargement, we can do turbinate reduction. Here's an example of a patient that has a deviated septum. It's blocking the left nostril there. We can go in from the inside. On the image on the bottom right shows an example of where some of these incisions are made. The red line is where we can make an incision to remove some of that deviated cartilage, and we actually save that cartilage for structural grafting. Everything that's to the left of the red line, that's all cartilage that we preserve. That's our support. Next slide. That red box is just showing us the cartilage is removed. Now, there's different approaches to doing surgery in the nose. There's, on the left, you see what's called endonasal. That's the approach I use. This is kind of endoscopic, if you may. Smaller incisions, quicker recovery, a little more challenging, a little bit harder to see, but there's no scars, quicker recovery. On the right, patients that have what's called open rhinoplasty, incision is made in the nose, and it's technically easier, longer recovery. The next few pictures will show some of these images. Here is on the left an example of a closed surgery. The cartilages in the nose, we're reshaping these cartilages, and they're in the nostrils, and then they get put back in. Whereas on the right-hand view, this is what's called open, where you lift the skin off the nose. Definitely more invasive, leads to a scar, and this is not the approach I use. Next slide. So for people that have collapse, what can we do for them? What we do is, if you look at the image on the right, there's it says alar batten graft. That is a piece of cartilage that we harvested from the septum and put it there to stabilize the airway. Next slide. This is a study that I did and published looking at patients that underwent surgery, this type of surgery. We wanted to look at their long-term outcomes. And essentially what we found was that after years, patients were still had a significant improvement in their airway that lasted a few years after surgery and were permanent. How do we do that? Essentially, we gave patients a survey that they took before and after surgery, and we followed them with these surveys. Next slide. Here's a patient that has kind of a crooked nose, a very narrow airway on the left. We added some cartilage to the middle of her, go back, please. We added some cartilage to the middle and enlarged her airway, gave her a straighter nose. The picture on the right is showing where the green is. That's where the cartilage is put. This is all put endoscopically, goes inside the nose. There's no scars on the outside, and her nose is straighter and she can breathe better. Next slide. Here's an example of the cartilage that's harvested. There's some drawings on the cartilage with purple ink. That's essentially showing different types of grafts that we utilize in the nasal airway. And this is where it's taken from. Next slide. We can also harvest ear cartilage for patients that have had previous surgery and they don't have cartilage in their nose. Or we can use rib grafting. This is a rib, a piece of cartilage off a rib. A lot of times I use this from a cadaver, so I don't have to harvest it from the patient. It's readily available, very safe to use, and it's a plenty of cartilage if needed. Next slide. So turbinate reduction, here's an example of a turbinate reduction procedure. On the left, you see at baseline, pretty enlarged turbinate. That's labeled IT, S is the septum. And if you look at essentially, there's a device, an electrode that goes, there's many different ways to do this, but essentially it shrinks the tissue and then it creates more space for the patients to breathe. Next slide. This was an article that I wrote looking at patients that had also allergies and underwent surgery for their obstruction. We also see a reduction in some of the allergy problems. And, the thought is that if you open up the airway, and patients are able to breathe better, then many of those allergens that would otherwise be stuck in the nose causing inflammation will easily bypass. Next slide. Next slide. And again, we use this nose survey to really look at nasal congestion, nasal blockage, difficulty breathing through the nose, any difficulty sleeping. And the results showed before and after, and this is actually, I do this on every patient. Every patient that has surgery gets a survey, so we keep track of this. And on the left, you can see the on the left is a postoperative. There's a reduction of severity from 0 to 1, which is no problem or very mild versus a severe to fairly bad. Next slide. And we see this in both the congestion, the obstruction, next slide, the difficulty breathing through the nose, next slide, the trouble sleeping, even and the inability to get air through the nose. Even patients that have difficulty sleeping, there's many different factors that affect sleep, but not being able to breathe definitely impacts your ability to sleep. So to conclude, we kind of went through a lot of information. We talked about patients that had nasal airway obstruction. Causes include both medical problems, allergies, or non-allergic problems, and then there's structural problems, and that's a deviation in a septum, a nasal valve collapse, which is weakness in the structure of the nose. And next slide. Oh, next slide. So, to summarize, one of the things I like to highlight is patients that have endonasal surgery. There's a lot of, especially family members that have underwent surgery in the past, they'll tell them, oh, I had my nasal surgery, it was pretty severe, I had packing in my nose. And, that's actually a lot has changed. We're most of our procedures tend to be less invasive as technology advances, and using a minimally invasive approach, such as the endonasal approach. Most patients, I'd say the vast majority have no packing in their nose. Most of them have discomfort for a day or two, and really allows for a quicker recovery. Next slide. So with that, I know we went through a lot of information. I wanted to make sure we left a lot of time for questions. And unfortunately, I can't see anybody. So hopefully a box will pop up here with some of the questions.
Okay.
We'll give you some time to type those in and go from there. Do they have access?
Everybody should have access.
And I guess for those that want to ask a question in private or have additional questions, okay, here we go. We have a question here. Why aren't allergic immunotherapies more widely used? That is an excellent question. Essentially, historically, the only way to have immunotherapy was to get shots. And shots, most people don't like shots due to the pain, and also very time consuming. Patients have to come into our office and get a shot and then wait 15 to 20 minutes to make sure they don't have an allergic reaction. So that's probably the vast majority or the reasons why patients don't want immunotherapy. However, with the kind of more newer technologies with this, I briefly mentioned that we can use drops, and drops, the way that works is our drops are placed underneath the tongue, and you're given a 3-month supply, and you can do this in the convenience of your home. The downside to the drops, the drops work better. The downside is vast majority of insurances do not cover the drops. So the average cost, I would say, is probably $80 to $100 a month for the drops, and they receive a 3-month treatment. Good question. So I have a question on how patients can schedule an appointment. Really it depends on your insurance. Most insurances allow you to kind of call our office without a referral. However, there are some insurances, and if you call our office, they'll tell you, you have this type of insurance. It requires a referral, and then you'd have to ask your primary care physician to refer you to us, and we'd be happy to see you. You probably need our contact information. Is that something that's made readily available?
I'm going to send it out to anybody that signed up through the Eventbrite at the end of the presentation.
I'm being told that at the end of our presentation today that our office information will be emailed to you. So for those that want it, I have another question here that's states that some people, when they're sleeping, or this individual has difficulty breathing when sleeping, which leads to loud snoring. So snoring is a complicated issue because there is multiple areas that can lead to obstruction in snoring. Snoring essentially is the sound that turbulent airflow makes. So is it possible to have snoring from your nose? Yes, it is possible. I would say the vast majority of patients, if they do snore, it's because there's an obstruction in the mouth or the tongue more specifically. Sometimes we can assess that by looking into, doing an examination, looking into the mouth. And if I see that it's very narrow and the nose looks pretty wide open, I can tell patients with good, confidence that your nose is not the problem. You probably have an obstruction when you lay back. Because when you go to sleep, your muscles get relaxed and your jaw relaxes, and your tongue, your lower jaw, which is attached to your tongue, will fall back, and that leads to the loud snoring. So that's probably what it is. And even if you can breathe through your nose fine, if you have a large tongue and a small mouth and the tongue blocks off the back of your throat, you will still snore. So, I tell patients most of the time, fixing your nose or improving your nose will contribute somewhat, maybe 50% chance, eliminate snoring. It will definitely improve. However, the vast majority of those patients tend to have large tongues or a small oral airway, just a small mouth. Yeah, septoplasty, another question, is an outpatient. It is an outpatient. On average, it's about a 20 to 30-minute procedure. It is outpatient, meaning you are asleep. Typically, it's done at McLaren Hospital as an outpatient. And what we typically do is we have patients come back and see us in a week. Most people say they have discomfort for a day. I would say up a couple days. I usually give pain medications. About half of my patients say they use the pain medication. The other half say they do not, Tylenol or ibuprofen. And that's pretty much it. That's assuming you just need a septoplasty. If there's other procedures involved, sinus surgery or nasal valve surgery, then it can add an additional 15 minutes for the structural part, or, depending on what exactly needs to be done. Let's see if we have any additional questions here. Again, this is the first time we've used this Zoom or this video meeting, so it's a little more challenging because typically I like to point to what I'm talking about. However, I think hopefully in the future we can resume doing our in-person lectures, because I like it to be more interactive and patients interrupting me so I can explain something, because in my mind, it's possible, it all made sense. However, I know other people's understanding could be quite different. I think that those were all the questions that we had. So if I missed anyone's questions, you can always email them to me. Again, that our information will be provided to you. And I thank you all for joining us today. And I guess we got it.
Have a good night.
Thank you. Stop. Yeah, I went really fast because, usually I'm used to being interrupted. So I have people delivering for